recording? All right, as promised, you guys know on Tuesday, Wednesday, I don't even know what day it is anymore, Wednesday, that my brain wasn't exactly in it. So these two concepts right here, I think I sent an announcement about it. I screwed up. Don't know what I was thinking. I was looking at it completely wrong. I'm going to stop recording because this is a pain in the ass. One more week. All right. I was looking at this from the perspective like these are your sensory receptors. No, your sensory receptors down here. Okay? So single point stimulation on skin, if you press weakly, it's going to go up this pathway, and since you've only pressed weakly, it's only going to end up traveling on the most direct neurons, heading up to the cortex. All right. If you look at this particular one right here, this is the axon coming up. It goes this way, goes this way, it goes up to this, but then it goes around and co-facilitates this neuronal pathway. So the reason with a weak stimulation that this pathway would go instead of these pathways is that you have these facilitator axons helping. So you have the main axon exciting the next neuron, but then you have two facilitator axons also exciting the next neuron. So instead of one contact point, you have three contact points, which makes it easier to send a signal. So that's why a weak stimulus will travel up this way and be detected as weak in the brain. You get a little stronger stimulus, you spread that signal out. Okay, so you press a little bit harder, that signal gets spread out, it's detected as a stronger stimulus. If you press really hard, of course, that will activate all pathways, giving you the strongest stimulus. We call this a divergent network. Okay? What was confusing me and why I just said, all right, I'll re-explain it, is I was looking at it top down. If it's top down, that would be a converging network. I'm like, why is it a picture of a converging network, but it says diverging network? I mean, I made the slide, so why did I do that? Because whatever happened, this is a divergent network. Anytime you want to amplify a signal, you have a diverging network. One small point can activate multiple points. That's a way we can amplify things. All right, I hope that makes more sense now. Second one, lateral inhibition. Again, I was looking at it this way. We're going this way. Okay, so you have 2 points on your skin right here. These points go up, and of course they branch out. But notice that the 2 points in the central nervous system overlap to some degree. All right. What happens with these overlapping? Everything's getting excited, but there are branches from, let's see, the right side, left side. All right, branches from the right side are inhibiting these close branches. Branches from the right side are inhibiting these close branches on the left side, and branches from the left side are inhibiting these close branches on the right side. So we're no longer getting signals sent in the middle, right? So you have activation here, but there's cross inhibition in the middle. So what that allows you to do is, all right, I got a lot of stimulation here, a lot of stimulation here. Your brain is saying, I have no stimulation here, so we're going to recognize these as two separate points spatially. All right, because of that inhibition. And again, this inhibition is happening at the level of the cortex, not at the skin. All right. And that's the basis of two-point discrimination, right? Because of this lateral inhibition. You're going to see that a lot of things in sensations rely on lateral inhibition to be able to detect. What would you call this? You're detecting what? If I have two discrete points, because I'm inhibiting the sides of my signal, we're detecting what? Edges of our signal. We're detecting the edges of our signal. Or if you want to put it a different way, we're providing edges to the signal.
Why is it called lateral inhibition as the part that's inhibited is the middle part?
Because it's lateral to the central part of the this is the middle of that. So it's lateral to the central portion. Because it could be doing it over here too. Another way to put this is, I'm standing here next to Nick. If I don't want signals from him to interfere with the space between me, I'm going to inhibit him because he's lateral to me. He's next to me. Same thing for me. Like, we want to keep our space separate. I want to keep my space separate. I don't care what you want.
So the inhibition's just truly in the middle part, like where there's absolutely nothing.
Right.
Okay, but there's still, even on the red arches, there's still some inhibition, but there's still signal because not everything's getting inhibited. But in the middle, there's nothing.
This is a gross simplification picture. You're gonna so like it's more complicated than what you're seeing here, and actually, these neurons are not going to directly inhibit these neurons. There are inhibitory interneurons in the way. Okay, so most of your inhibition will occur right here. A little bit of inhibition here, less inhibition here, less inhibition here, coming from this direction. Less inhibition here, less inhibition here, less inhibition here, coming from this direction. Okay. Now, if you didn't have these inhibitory signals, you would have this blue line. Okay. But because these two pathways are inhibiting each other where they overlap, you're able to detect them as two discrete signals. Does that help? Maria? She's still got a confused look on her face.
So the blue is not what you have because of inhibition. It's what you would have if inhibition wasn't there.
Okay, yeah, I'm sorry. So the blue is, if we had no inhibition, that's what it would look like. The two reds are what the inhibition would produce. So, yes, sorry. Explain the graph. This is why I'm not a research scientist. There's other reasons. All right, let's talk about eyes. We're not going to go into as much of the structure. We're going to mostly talk about the function, the physiology of it. So a lot of the structure you should have already seen in the anatomy portion of this course. So just to remind you, palpebrae, levator palpebrae superioris, which is an item on your checklist that you need to be able to identify in the right. That controls this. Okay. Who in here wears contacts? Jesus. All right, a lot. Me too. Have you ever had really dry eyes and you try to take out your contact and you literally pull like the skin on your eye too? That's your conjunctiva.
Almost every time I take out my contacts.
That's your conjunctiva. I remember pulling it one time.
You have the worst eyes.
I remember one time I was pulling out, I was like, Jesus, what? Like, oh, okay, I didn't pull it out this far, but like, that hurts. It really hurts. The thing about the conjunctiva that a lot of people kind of confuse is that the conjunctiva is a clear layer covering, right? The whites of our eye and it's highly vascularized. So when our eyes get really bloodshot, it's not the sclera, the white part that's underneath, that's getting bloodshot. It's that conjunctiva, that clear layer. All right, that's getting. And why does it get red? Because it's irritated. What happens during irritation? Inflammation. What happens during inflammation? More blood flow to that area. So that's why you don't see it on a normal everyday basis. But if it's inflamed, you do see it because there's simply more blood flow going to that area. Conjunctivitis. All right. Of course, we have eyelashes here, and eyelashes are not to look pretty. That's not their point. Their eyelash. Well, I guess it works sometimes. You're seeing. I'm not speaking for myself. But their design is to, like something that's flying towards your eye, it hits your eyelash, and what do you do immediately? Close. It's a reflex. Okay. And then, of course, we have our lacrimal glands and lacrimal ducts. Important thing to remember, tears are produced here. They come down and they drain here. When we are crying, we get a stuffy nose because the drainage drains into our nasal cavity. All right, eye muscles. We have 6 of them, right? And we have 3 cranial nerves that control them. We have 2 up and down muscles. That would be our superior and inferior rectus. What do they allow our eye to do? Our lateral and medial rectus. And our oblique muscles. Rotate nasally, rotate temporally. All right. That's another thing it's weird when you talk about the eyes, you don't talk about medial and lateral. We talk about nasal and temporal. Nasal, temporal sides. Okay. All of your eye muscles are controlled by what nerve? Cranial nerve. 3, except for 2 of them. Your lateral rectus and your superior oblique. Okay, that's cranial nerve 6 and 4, respectively. All right, and of course, our eye actions are movement. And I think we covered this a lot in anatomy lecture. But in order to explain why, when you are testing for vision, you guys, bless you, I had you guys, some of you, I said, how do you test cranial nerves 3, 4, and 6 at the same time? Some of you did that, right? You remember that? Went in the check-off things we did this week. You did. Had your patient follow 6 cardinal fields of gaze. Okay. You're testing those. You're testing each individual muscle. I posted 2 videos that have animations that help explain this. So if you're confused, I highly recommend going out and watching them. They're really good. The first video, let me just pull it up real quick. I'm not going to play them, but this video explains all your rectus muscles, and it says part 1 of 3. I don't think they ever did a part 2 and a part 3. I can't find them anywhere. I went to the site. I went to the YouTube channel. I cannot find them anywhere. So there's only part 1. If you can find part 2 and 3, email me and let me know. But don't spend time looking for it. So the second one is explains more of the oblique muscles and how they work. Okay, so this would be part 2 of this part 1. Stupid. I mean, maybe they ran out of money or time. Medical students usually do these videos a lot of times to make a little extra money. Hint, hint. Like, you guys aren't allowed to work, but while you're studying, you can make videos and say, hey, everybody, guess what I learned today? And if you're already doing that, I want some royalties. So, when we're looking we're always facing this way, right? Our eyes are facing forward. But that's not in the same plane that our rectus muscles are oriented. All right? So our rectus muscles are oriented superior and inferior in this plane. So like out that way. Right? That's the way our eyes are, our sockets organized. Right? So it's this way, but we're facing this way. So if we want to truly test this muscle, we have to contract that lateral rectus, orient our eye this way, and then up and down to test the superior and inferior rectus muscles. Does that make sense? So that's why when we are testing superior rectus, we look laterally and upward, inferior rectus laterally and downward, because we're forcing our eye to get into the plane of where the muscle is, and we're truly testing just that muscle without the aid of others. Okay, so that's why you're looking in those directions instead of straight out and up and down. That's testing multiple muscles. All right. Same thing for the inward. If you're going inward, you're strictly testing the obliques up and down. All right. As far as eye structure goes, I'm not going to go into all the details of this. We might come back to this as a reference. But when we are dealing with vision, what is our stimulus? Light. All right, light. So light enters here. Okay, it's got to go through this clear part right here called a cornea. Then it's got to go through this fluid-filled chamber called the anterior chamber that has your aqueous humor. All right. Then it's got to go through this part, this black part, the hole. All right. What's that called? Pupil. What's the pupil surrounded by? The iris. And the iris is what gives our eye color. The iris is also the thing that when you shine light into your patient's eye, it's going to constrict or dilate. All right. So that iris, even though it's there was something floating around in some social media thing that showed like this close-up of the eye. It's really a magnificent looking structure. It's really cool. I'm getting chills thinking about it. I don't know why. I'm a nerd. All right. So there's your iris. You shine light, it constricts. Why does it constrict? Because that's too much for your retina to handle. So it's going to be like, hey, let's let less light in. Okay. If it's dark out, you take the light away, it's going to dilate because, hey, we don't have enough light, let's let more in. All right? Then we have this lens. All right? And the lens is what allows us to focus that light on specific areas of the retina. So when light is passing through here, it's going to hit different spots on the retina. It has to go through this vitreous humor. You guys ever done an eyeball dissection before? Like a cow eyeball? Second grade?
Second grade, or like elementary school. They kept falling in my lap.
You. So it's been a while.
Yeah.
Okay. So I did this with my undergraduate students. You open up the eyeball and you dump out the contents. Bless you. The vitreous humor. Do you guys remember what that looked like? Jelly, like a little thing of jelly. So it's not, when they say that this is a liquid chamber, it's not really liquid. It's a jelly-like substance that's in there. And one, it has to be clear, because if it's not clear, what doesn't happen? Light doesn't pass through easily. So it's got to be clear, and there's enough of it to where it's pushing pressure against the retina. Because another thing, if you've ever dissected this eyeball, and you take all the stuff out, the retina just kind of falls off. It's not attached to the back of the eyeball. It's the pressure from this vitreous humor that is forcing the attachment of the retina to the back of the eye. Does that make sense? So it's a pressure thing. It's not directly. We don't glue it on. All right. At the back of your eye, there's this thing called the optic disc, and when you guys do your fundoscopic examinations, especially next semester, you should be able to identify where the optic disc is. And I think I talked about this a little bit in the anatomy lecture too. That's where your optic nerve is. All right. Since this is where all of the retina is converging and going out, there's no photoreceptors there. So that is what we refer to as the blind spot of your eye. All right, you guys can all test this where your blind spot is. Cover one eye, look ahead, and move something. I don't know where it is. Anyway, or move it. At some point, this disappears. You can't see it anymore. The reason for that is that blind spot. You guys ever done that experiment before? It's kind of, actually, no, here's how you do it. Not working. All right. So there's like a little card. It's about the size of a microscope slide. There's a plus on one side, a dot on the other, and you close one eye and you look at the thing on the opposite side, and the thing on this side should disappear. Okay? That's a test of where your blind spot is, and it's a certain distance away from your eyeballs. The other spot that you should be able to recognize is this fovea centralis, and the fovea centralis is where your most acute vision occurs, and in there, that's where the highest concentration of color receptors are located. Okay, so clearest vision, highest concentration of color receptors. All right, so what we want to talk about is what happens when light gets to this retina and how it's sent to the brain and what happens once it gets to the brain. That's what the rest of this is going to be oriented towards. So the retina is actually way more complicated than a single layer of yellow tissue at the back of the eye. There are lots of neurons in there that form a lot of different pathways. It's really confusing, so we're going to only highlight a few of these things and talk about what they do. So light's coming in. It has to pass through all of these layers of cells and get to the very back until it actually activates the photoreceptors. All right? And the question usually is, if it's got to go through all of those cells, doesn't that block the light? And the answer is no. Cells have no color to them, so it just transmits light right through. All right, so that's what this means. The neural elements, all of this stuff, are virtually transparent in live tissue. All right, every retina has about 100 million rods. Rods are for detecting. Is it in there? Oh, night vision, black and white. Cones are for detecting color vision. We have about 3 million cones. Right, so not as many cones as we do rods, but what do we see in color? Okay, so that means that color is secondary to the other things that the retina provides us. Okay, and we have 1.6 million ganglion cells, and these ganglion cells are important because they are the only cells, and you'll see this in a few minutes, that are sending action potentials. They are the only cells that are going to be sending action potentials.
Color vision is like gradual. Like if we had fewer cones, we wouldn't see in color vision, even though we still have cones. Or is it just if you have cones, you see in color vision?
If you have cones, you're going to see in color vision. Think of it this way. Go back. Let's go back to the 80s. All right. I'm a kid. And we have these giant-ass TVs, right, that display X number of pixels, color pixels. All right? Let's jump to 2005, 2010, where we're getting 720p, 1080p. Now we have 4K resolution. So what the number of color cones allows you to do is increase your resolution. Let's watch Stranger Things, 80s. Captain Marvel, 90s. Anyway, bad joke. Some of you fellas, you're like, shut the fuck up, just get on with it. All right, so here's how the rods and cones are organized. This is the cell. To me, it looks like a comb. This is the back, all right, and this back, against the back wall of the retina is where our pigment layer is going to be. And if we look at the pigment layer, even rods and cones both have pigments. They're just different kinds of pigments that pick up different wavelengths of light. So they're stacked like this. All right, so you have these stacks of pigments, stacks of membranes that contain pigments, rather. All right. Then you have like the bulk of the cell, which contains mitochondria and all the organelles that a cell would normally have. And then you have the nucleus, and then you have the synapse. So light's going to travel this way, but the information received by the rods and cones is going to travel back this way. Right? So light travels towards the back, the signal travels back towards the front. All right. Lots of information about rods and cones. The important things, I already did the highlighting for you. Okay? Rods are highly sensitive. What that means is that it takes very little light to activate them. So they're specialized for night vision, right, where there is very little light. Cones have a lower sensitivity. That means it takes a lot of light to activate them. That's why we see color vision during the day. That's why at night, everything looks a little bit duller. You don't see the colors as much. All right. Rods have a high amplification. Remember, amplification is through diverging pathways. Okay, so there's a high level of amplification with rods, low with cones. You don't need as much amplification. All right? Because of all this, rods have low acuity, okay, which means that things are not as crystal clear with rods as they are with cones, because they're scattered across the retina, whereas cones are concentrated in that one spot, okay, the fovea centralis. And then, of course, rods, achromatic. What does chromatic mean? Color, without color, achromatic, without color. And cones are trichromatic. So you ever wonder why televisions are based on red, green, and blue? Because vision is based on red, green, and blue, and how they blend with each other. All right, so most of everything we're going to be talking about applies to both rods and cones. The same processes apply, so we'll just talk about them generically together. The pigment, oh, no, this is something different. So, at the back of the retina, behind all of these, we have something called the pigmented layer. And it's, again, if you go back to that cow eyeball, you look inside and it's completely black inside, right? Do you remember that? Why is it black? Because you don't want light coming in and scattering all over the place. What's going to happen if you have light coming in and scattering all over the place? What's your vision going to look like? Crazy. It's bleached. It'll be completely bleached. It's like, it would be like looking directly at the sun. Okay? So you don't want that light scatter. So you have this pigment layer in the back that's black, what does black do? It absorbs light. So light doesn't scatter, your vision tends to be more clear. In animals that don't have or have less black pigment, and there are, their vision is not as highly acute as those who do have black pigment. Okay? So how does vision work? How does the photochemistry work? All right, you have this molecule called rhodopsin. All right, it's made up of a couple different molecules. I don't even give a shit that you know that. When light is not hitting rhodopsin, it is in a cis conformation. All right, and if you look at the cis conformation, it's bent. Okay, cis conformation is bent. When light hits, what that does is it converts the cis conformation into a trans conformation. That is a physical structural change. And because of that physical structural change, it will become active and activate a certain pathway that will allow channels to open and some kind of electrical change to happen in the cell. All right? So light activates a chemical, and that chemical begins a signal transduction pathway. Where have we also seen a signal transduction pathway that involved receptor binding, production of cyclic AMP? No. We didn't produce cyclic AMP there. We did it Wednesday. Olfactory senses. Remember that you bound to a receptor. It activated a G protein, which activated adenylate cyclase, which produces cyclic AMP, which then opens sodium channels. Okay, this is another example of that. You convert to the trans conformation. That will start a signal transduction cascade that opens sodium channels. Actually, that affects sodium channels. All right, this is where it gets a little weird. Because when we think about activating something, what do we usually think about happening to sodium channels? They open. This pathway closes them. Like, what the fuck? All right, so I've kind of labeled the steps here as I go on. So light activated rhodopsin activates a G protein. Okay, that activates cGMP phosphodiesterase. That's different than what we did before. You already have cGMP, which is GMP, that's a circle. And this phosphodiesterase breaks that circle, and you just have cGMP. I'm sorry, not CMP. You just have GMP. You just have GMP. So it breaks the circle, you just have GMP. All right? Cyclic GMP is bound to that sodium, keeping the channel open. So as soon as you activate this pathway and cGMP decreases, you don't have anything to bind to that receptor anymore. So that receptor closes. All right? If that receptor closes, sodium is no longer getting into the cell. If sodium is no longer getting into the cell, you are getting to a more negative potential. What do we call that? If we're getting more negative? Hyperpolarization. All right? But wait. I thought if we're activating something to do something, we depolarize. All right? What did I say about these vision pathways and action potentials? We're talking about rods and cones here. This is happening in rods and cones. Do they send action potentials? No. What's the only cell that does? The ganglion cells. All right. So what we're doing is having light shut down these cells. So they're always sending a signal when it's dark. When it's not dark, they don't send a signal anymore. That's weird, man. All right. When they're activating, when in dark situations, they're releasing glutamate as their neurotransmitter. But when light when light activates this pathway and it hyperpolarizes, we decrease glutamate transmission. Right? So light is sending inhibitory signals. All right, so here's how this looks. This is, again, your rod or cone. And as long as it's dark, we call this dark current, sodium's going to be entering, potassium's going to leave. So you have this current flow going into and out of the cell. All right, positive ions entering, negative ions or positive ions leaving. That's a current flow. All right, and then you have this sodium-potassium pump that's re-equilibrating sodium and potassium all the time. All right, so that's going on. As soon as light hits, this dark current stops. Right? Turns out that the more light that comes in, the more rhodopsin you make, and the more you shut these down. Okay, the more you shut down this dark current, and the less signal you're sending. All right, so that's the basis of how this works. All right, so that's what's going on here with the rods and the cones. All right, only ganglion cells will have the action potentials. So what happens is, this is the important part of this. Right, the ganglion cells, since they're the only ones that are going to be sending action potentials, they're going to send the signal to the brain. All right, and they are constantly active because we're sending glutamate from the rods and cones, activating the cells in between, and then ganglion cells are going to be like, all right, we're going to keep sending signals. So your dark signals to the brain are like this. When light hits, we are interrupting that pathway. We're interrupting those signals. All right, when light hits, we're interrupting those signals. So what we're creating is a light-based interruption of a dark signal. What's that going to produce? What's that thing we talked about earlier when we talked about lateral inhibition? We're producing edges. All right, and what's the whole basis of our vision where we can tell that table from the wall? That's an edge. All right, so these visual signals are superimposed on this constant activating background. Activating, activating, not. Activating, activating, not. Okay? If you're really confused, that's okay. That's good. Because I don't fully understand, like, the big picture of how this works. Like, I can't tell you, how does that mean that I can see you standing there with the blue sweatshirt, rubbing your hands, writing on your thing? I'm not an expert in that field. Okay? But I want to get you guys just at least a sense of how this works. All right? So that's going to create contrast borders. Patterns. It's going to create visual patterns. Okay, so one visual pattern might look like this. Another might look like that. All right, because remember, we're producing electrical signals. We don't see anything in our brain. So this is converting light to electric signals. All right, color vision, cones. The difference between them is a type of pigment used. So here would be the pigment that's used in rods. All right, the pigment that is used in cones. The blue is a shorter wavelength. The green and reds are longer wavelength. That's the only difference. They just operate at different wavelengths. They are activated by different wavelengths, we'll put it that way. So, if you have a lot of blues coming in, you're going to activate your blue cones. But if you have some green and reds coming in as well, you're activating blue cones, but you're superimposing green and red on that as well, and they blend together. All right? And then these rods, what they will do is produce borders between these blends, and that's what allows us to see the edges. All right. I'm going to call this slide, "Why do you get pissed off when mom comes in and turns on the light when you're dead asleep in the dark?" All right. Cones adapt very rapidly. So if I have light in here and I turn on more light, my cones are going to adapt really quickly to that. And I'm not going to have much interruption in my vision. But rods adapt very slowly. This is why when it's dark and somebody flips on the light, you're like a vampire for 5 minutes. Okay? Because they haven't adapted to that rapid increase in light. So you're like, a little bit at a time, a little bit at a time. That's why it hurts. Okay? Because rods adapt very slowly. And the adaptation is based on, remember, we convert from cis to trans. Adaptation is converting it back to cis. All right, it takes longer to do that for cones than it does for the color pigments. All right. Does this look familiar? Lateral inhibition. Works in your eyes as well. What does lateral inhibition do? Okay. We have light coming into a spot on our retina. What happens is all the cells in the spot that it's hitting, they're going to be activated, but the cells that are surrounding that spot are going to be inhibited. And what that allows you to do is create a specific point or line or border so you can see this clearly, but everything around it is not activated. Again, this doesn't allow you to see edges, but this enhances what the edges look like. So instead of something that's like blurry, and you can tell, like, yeah, I can tell there's a difference between that thing and that thing there. Lateral inhibition would clear that up and make it look, okay, that is a table, that is a wall. Okay, so the way this works, again, we're converting to electrical signals. This is our background. If I turn lights on, I'm going to have these signals, then they're going to adapt. Right? I turn it off, it goes back to our regular signal again. It adapts back to the regular signal. In those areas around that, we have a regular signal. Light turns on, no signal whatsoever. Okay? Showing that those cells are inhibited. And then as soon as the light turns off, we have them activated again. Okay, or sending that dark signal. Okay. How do we get these signals to the brain? And what does the brain do with them? All right. This is important to this actually is more relevant to what you guys are going to be doing as practitioners. All right. The way vision works is we have a right field of vision and a left field of vision. All right. Anything coming from the right is going to hit the nasal retina of our right eye and the temporal retina of our left eye. So all light coming in, nasal portion of this eye, temporal portion of this eye. All right. All of that is going to give me information on what's over here. All right. So the retina then, from the nasal portion of this eye, is going to cross over at the optic chiasma and head down the left side of the brain. The information from this eye is going to head down the optic nerve and stay on the same side. All right? So what that means is that all the information coming from your right field of vision is going to be processed in your left brain, which is kind of makes sense, right? Because that's what we've described for muscular responses. That's what we've described for sensory responses. It makes sense that your vision would work the same way. Right? If you notice here, same thing happens on this side. Everything from your left is going to go to the right side of your brain. Okay? Does that make sense? So then what happens is, in your, and there's a picture of this later on, in your occipital lobe, you get the left picture on the right side of your brain and the right picture on the left side of your brain. All right? And since there's a significant amount of overlap between those two fields of vision, there's a point at which the pictures overlap, which allows you to put them together. So what your brain is doing, in other words, is lining up where the edges of those pictures are so that they coincide with each other. So you get a full picture. All right? In order to go to the occipital lobe, they have to pass through, like every other thing, the thalamus. All right? And the part of the thalamus they pass through is called the lateral geniculate nucleus, LGN. All right, so that's our main vision pathway. Crosses over, goes to the through the thalamus to the occipital lobe. All right, but we also have projections that go to lower areas of the brain as well. All right, remember the occipital lobe is cortical, so we have subcortical regions it goes to as well. For example, the suprachiasmatic nucleus of the hypothalamus, basically that says it's a little area of the brain that's above the optic chiasma. Okay? That's thought to help control circadian rhythms because it's all based on what? Light. When it's light out, when it's dark out. So what endocrine gland would that work with? The pineal gland. All right? We have projections that go to the midbrain that allows us to have our pupillary light reflex. Remember the superior colliculi? Visual reflexes, inferior auditory reflexes. So they'll go and cause that pupillary light reflex. So that is the pupillary light reflex is a visual reflex. It's one of your visual reflexes. All right? And we already talked about that. Yeah, there's evidence it does, but there's evidence it does in lower animals. But what really happens in humans, we can't. It's not ethical to get in there and look. Put it that way. So yes, good. Pick up. All right. I want to finish vision and then we'll take a small break. Okay. Remember how touch sensations were highly organized? You have like different columns in your brain that were dedicated towards different, not just areas of your skin, but different sensations as well. Vision is no different. So when you have fields of vision going to the lateral geniculate nucleus here, we have some layers receiving input from the ipsilateral eye, which means if this is the left part of the brain, it's coming from the left eye, ipsilateral, same side, and some layers coming from the contralateral side. All right. The important thing here, though, is what are they doing here? What's happening here? They're converging. All right. So what you're doing is taking all of these signals from these different areas and putting them into one pathway. Okay, all that information from all these different areas about what's happening in front of me, converging into smaller areas. All right? So we're concentrating information. All right? Then it goes to your cortex, and that's what allows us to see. All right? This is based on what's happening in the fovea centralis. And again, what's the fovea centralis? Our most concentrated vision, our clearest vision. All right? As we move out of that area, 30, 60, 90 degrees, that's what allows us to see 30, 60, 90 degrees from the fovea centralis. Okay? So fovea centralis is processed here, then peripherally on the retina is processed a little bit farther away. So peripheral information is processed in different locations than the fovea area is processed. All right, so what that tells us is light's coming in, bouncing to that specific spot, that goes to one specific spot of our occipital lobe. Go 2 degrees, that's going to go to a different spot. Go 4 degrees, that's going to go to a different spot. 6 degrees, that's going to go to a different spot. So I always wonder, like, all right, light is just entering. How do we discreetly separate all that, right? Because different spots of our retina are going to different spots of our brain. You really want us to know all this? Okay, so that gives us like the whole picture. And then information spreads out from there to these visual association areas, and you guys know what these are by now, and that will tell us more information about what is out there. Okay, visual association areas. So I can tell that that's green. Green's my favorite color, and it makes me happy. So in the end, this is kind of the summary of what we just talked about. We have this picture. We know where it comes in. We know what happens here in the thalamus. Then it gets projected to the occipital region.
I didn't get that. Could you try again?
I'll tell you about this story in a minute. And so here's our picture. Remember, what's on this side comes to this side, comes to the right side. What's on this side comes to this side. We get this upside down picture, right? Same thing that happens in a camera. All right? Then we have to process that information. We have to turn it around and make sense of it. So all that information, that picture that's back here, gets put into the parietal lobe, gets put into the temporal lobe. What's happening in the parietal lobe is going to tell us, where is it? Where are things in space? I can tell that that table is there, and that Christina is there, and that Kendall is there, right? That's happening in the parietal lobe. I can tell where things are in relation to each other. Temporally, I can tell what it is, all right? That is a table. That is Kendall. That is Nick, all right? So that's happening in the temporal region. So it's not just a matter of seeing things, it's a matter of being able to make the associations of what it is. And again, what's that based on? Experience. So even if a baby could talk, they couldn't tell you that's a table because they've never seen one before. But you've seen tables over and over. Somebody in some third world country that doesn't even have sewage or running water comes to this classroom and sees that. They're like, what is that? They don't have a picture of what it is, right? But once they've seen it, now they have this picture, and if they see it again, they can tell what it is. All right, so association areas.
So where is it? Is in the occipital or the parietal?
The parietal lobe. So that information is being processed from the occipital to the parietal lobe, like in that direction. Okay? I'm not going to go into the details of this. When it says left, it's referring to left. When it says right, it's referring to right. So it's talking about the orientation of this picture right here. Speaking of what is it and where is it. All right? All this is saying is that when you come down here to the lateral geniculate nucleus and you condense information, some of that information gives you fast black and white information that's rapidly changing and allows us to see borders. And some of that information gives us spatial detail and tells us color. All right, so all of these intermixed things converge and tell us, I have this color situation, I know exactly where it is, and I can see the borders between everything and tell them apart. All right, so again, strictly occipital lobe, that very back part, that brain that you guys have up in the second anatomy lab that has that dark purple in the back. That's your primary visual cortex. That's mainly concerned with contrast in the visual field. Like, can I tell things apart from one another? If I didn't have that, everything would be just one big blurry thing. All right? Patients who have dysfunctions in this have hazy vision. It's like when you look at the sun, like, all right, don't look at the sun, but a bright light. Shine a flashlight in your eyes. And then look out to something. Can you see it very clearly? No, this is why. That would mimic what patients with a dysfunction have. Actually, there's a really interesting phenomenon where you have damage to the occipital lobe, but your eyes work fine. And the vision pathway, like your eyes work, they can see, but since this doesn't work, you don't see anything. Really weird. I don't remember what it's called. If I think of it, I'll shoot a announcement out. So the greater the sharpness of the contrast, the greater the degree of stimulation. In other words, the more difference you have between one edge and another, the more greater the stimulation is going to be. This is why we are attracted to edges. This is why we're attracted to edges. This is why somebody who has like very sharp cheekbones and why you put makeup on makes it more attractive, because it stimulates you more, right? You're creating edges. Okay. Let's take a break because I'm tapped out. let's finish. Yeah, we will finish. Is that all the stuff? Yeah. Okay. We can do it. All right. Ear structure. Again, I'm not going to go through a whole lot of this. If the stimulation for our eyes was light, what's the stimulation for our ears? Vibrations. Strictly vibrations. So vibrations come in this canal. They vibrate the tympanic membrane. Right? That starts. All right. These are air vibrations. Now we have a solid physical vibration. So vibrates the malleus, incus, stapes. All right, and that's attached. Who was I with? Who was with me yesterday when I was doing this? Attached to an oval window, and it goes. And on the other side of the oval window is liquid. So you've just turned a air vibration to a physical solid vibration to a liquid vibration. All right, so if you want to demonstrate this, go home, fill up your sink with water, get a speaker, turn up something with bass really loud, and put it right next to the water. What's going to happen? That water is going to start to vibrate. Or, better yet, take a wire, put it around the speaker, and put the wire in the water. Air vibrations, physical vibration, that'll translate into water vibrations. That's exactly what's going on here. Okay? It goes to our inner ear. Air vibrations will travel this way. All right? So they're going to travel to our inner ear, which is in what part of our temporal bone? The petrous part. Sweet. All right? They're going to travel here. The other part of our inner ear that's in the petrous part of the temporal bone is over here, and that's related to vestibular function or balance and proprioception. All right? So the cochlea for hearing, everything else, proprioception and balance. All right? So we're going to start with the cochlea. So when we talk about people that have cochlear implants that hit them here, it's basically doing a similar job to what the cochlea is doing, and they have it implanted outside their head instead. All right. This part, external ear. This part, middle ear. This part, internal ear or inner ear. Did I bring that in? Nope. We'll use this. Okay. So, I think the way that they present this is kind of confusing. So, like, I've spent hours like coming up with examples to try to like, how can I get this across? So, the cochlea, it looks like a snail shell, right? And the snail shell has three chambers: the scala tympani, the scala vestibuli, and the scala media. All right, and it circles all the way around and comes to a point. So that's the equivalent of taking this wire, wrapping it around until it comes to a point. So all three of those chambers are going all the way around. So if I unwind it, I have all the chambers in a linear fashion. Does that make sense? All right. Why is it coiled like that instead of linear like this? What did you say?
Longer distance.
Okay.
Amplification.
No. You're closer. You're thinking the right thing, but wrong direction. Yes. So it fits into a smaller space. Right? We've coiled it up, fit into a smaller space. All right. The amplification signals come from within certain structures of that coil. So yes, it's a way to conserve space. In fact, I think there are examples of lower order animals where it is straight. So at some point, I thought it was easier to pack into this condensed form. So anyway, that's what we're looking at here. So this oval window vibrates fluid, and it goes all the way around. Vibrates in the oval window and goes vibrates the liquid in the scala vestibuli. Okay, so the liquid gets vibrated here. The vibrations coming in go through the scala vestibuli. It goes all the way around to the top, to the tip. So if we spread it out into linear, it'd be the very tip. And then it comes back down the scala tympani. Okay, so those vibrations go all the way up the scala vestibuli, and they come back down the scala tympani. And then there is another window within your ear called the round window, where those vibrations will dissipate. Okay, so we've taken air vibrations to physical vibrations to fluid vibrations and traveled them all the way down this system and back, and then got rid of them. Okay, why do we get rid of them? Because in traveling through these tubes, they've activated certain receptors to allow us to hear. All right, so how does that work? Okay, so I've already talked about this. The tip, where it goes from one chamber to the other, the scala vestibuli to the scala tympani, that's called the helicotrema. Helicotrema is the tip. So again, if I draw that out, it would be the very tip here before it comes back. All right. As these vibrations are moving down these tubes, whether they're going out or whether they're coming back, they'll still vibrate. They're going to vibrate something called the basilar membrane within this middle layer, the scala media. Okay, this is the basilar membrane. So it's going to vibrate that basilar membrane. Okay, the way it works is that closer to the oval window where the vibrations are being generated, that membrane is going to be moved by high frequency sounds. As you move further and further away towards the helicotrema, that membrane is going to vibrate low frequency sounds or respond to low frequency sounds. Okay, important to remember. Closer to the oval window, high frequency sounds. Farther away, low frequency sounds. So, if a high frequency sound comes in, it will vibrate right away, right? Then it won't vibrate, and then it'll come back and it'll vibrate again. Okay, so that's important to remember. That vibration travels all the way through. So it's going to activate out and it's going to activate back. How fast do you think that occurs? That sound wave traveling from the oval window to the round window? Less than milliseconds. Right, less than milliseconds. So I know that's kind of hard to conceptualize, thinking in those small terms. So this picture right here is just kind of showing you an example of what this looks like. So sound waves going in, sound waves coming back. Fluid waves, rather. All right, so let's look at that basilar membrane and the structures within it. So on the basilar membrane, which is this right here, you have this thing called the organ of Corti, and that's this whole thing right here. Corti is the a-hole that discovered it and named it after himself. Okay, and these are in the scala media all the way through to the helical trema and back. All right, they are what, when that basilar membrane vibrates, they are what's going to detect that vibration and send electrical signals. All right, so the organ of corti detects the vibrations and sends electrical signals through what nerve? Not the vestibulocochlear, just the cochlear, right? Because we're only in the cochlea, and then that combines with the vestibulocochlear. All right. Within this organ of corti, we have these little things called hair cells. They're called hair cells called stereocilia. So that can be used interchangeably. Hair cells have stereocilia on them. All right. Those are what generate the action potentials. All right. So how does that work? These hair cells are attached to this thing called a tectorial membrane. It's really this tectorial membrane that's what's going to be doing the vibrating. And when it vibrates, where's my stuff? It's going to move back and forth. And as it moves back and forth, these little hairs move back and forth. Okay? So this would be an example of what those hairs look like. Two things to notice about these hairs. One, they're shorter on one end and longer on the other. Right? They're short on one end and longer on the other. When the bending occurs towards the longer end, or towards the tallest of those cilia, the hair cells depolarize. Okay? If they come back this way, they hyperpolarize. All right, the other thing you should notice about this is that when we depolarize, what ion is going in? Potassium. Why is that weird? Normally sodium goes in because it's in high concentration out of the outside. Where's potassium in high concentration? Inside. So what does that mean, probably, about the concentration of ions within this organ? They're not the same as what they are in the rest of the body. Okay, so when you depolarize, these hair cells will release neurotransmitter. The neurotransmitter that they release is called glutamate. And that will activate the afferent going towards afferent neurons that will become part of the cochlear nerve. All right? So depolarize these hair cells, releases neurotransmitter, activates the next neuron that's part of the cochlear nerve. That's how it works. I'm leaving out some details. Okay, this concept called the place principle. All right, place principle determines the sound of frequency perceived. Remember, we said that along. So this is that. This is the cochlea. It's spread out in a line. All right. The reason why I went through this whole demonstration here is because in your book they turn it into a line. All right. So fluid is vibrating in that direction. All right. And we said that here detects what kind of vibrations? High or low frequency? Where the X is. high. High. At the Y, detects low frequency vibrations. So what this place principle says is that when a vibration comes in at a certain frequency, it's only going to vibrate the area that's geared towards that frequency. So if it's operating at frequency A, and A is right here, only this part of the cochlea will vibrate. All right, and that helps us determine the pitch of what we're hearing. High frequency versus low frequency. Okay. What would determine how loud it is? If you have larger amplitude vibrations coming in, and instead of the basilar membrane vibrating like this, it vibrates like this. Okay? That's what determines loudness. So if you think about it, this whole basilar membrane that's vibrating and the tectorial membrane that's attached to it is organic tissue. So if you send in really loud sounds and make it go like this, what could possibly happen? Breaks off. What happens to your hearing? You lose it, right? Or you lose certain frequencies. This is why listening to loud sounds causes deafness. Does that make sense? I mean, I'm going to be deaf at some point because I refuse to listen to my music low. Did anybody go see the fireworks on the 4th? Or not on the 4th. Nobody does them on the 4th anymore. My favorite ones are the ones that like make your heart skip a beat because they're so like boom. Love those. Oh my god. Who said that? Who said me too? You?
Oh yeah, for sure. I didn't say that, but I agree.
Whoever said that, rock on. All right. The reason why we have this scenario where they vibrate at different frequencies or detect different frequency vibrations is that related to the length of the fibers. The length of the fibers out here towards the helicotrema is much longer than the fibers towards the oval window. So they're going to vibrate easier, but if you have a thicker membrane, they're going to take more to vibrate, so that's the low frequency sound. All right, when we talk about sound, we talk about it in terms of decibels. Actually, maybe you guys never thought of this. Deci is a unit, which means 10, right? So really we're talking about bells, right? So, right here, 1 bell is a 10-fold increase in sound. Okay, so that means 0.1 bell is a decibel. All right, so is it easier to say things are 10 decibels, or is it easier to say things are 0.1 decibels? Like, so we convert it into something that we can use on a daily basis. That's why we use decibels instead. All right, and basically it's a measure of sound energy. Because remember, if it's a soft sound, the waveform is going to look like that. That is a certain amplitude. But if it's a louder sound, the amplitude is going to be much higher. All right, you're displacing waves much more greatly. All right, so this would be a higher decibel. This would be lower. And I don't remember. There are guidelines. I'll find them and I'll post them on Canvas for you guys. Guidelines as to what safe levels of sound are. All right? And if any of you wear an Apple Watch with headphones or an iPhone with the headphones, your phone now tells you you should probably turn down your volume because you're going to hurt your ears. I turned that feature off because it was obnoxious. I'm like, no, I'm not turning it down. And if you turn it down for me, I'm throwing you. All right, so when sound is generated, it's going to go into the cochlear nerve and into the medulla. All right, so sound enters into the medulla. So it's not entering into the spinal cord. Why is it not entering into the spinal cord? That's a good question. Why would it?
Go down and then back up.
Right, it'd have to go down out of the skull and then come back up. That doesn't make sense functionally. So a lot of people don't think about that because we think about things coming in through the spinal cord and going up. But if you're already in the head, it wouldn't make sense to go to the spinal cord. So you got to go in through what's already there, and that would be the medulla. That's the closest spot. All right, and of course, then they're going to go up. Some fibers stay on the same side, and a lot of them cross over. Okay, and where they end up going, actually, I don't even care that you know any of this. 1 to 6, they go to the temporal lobe. Okay, fuck it, we'll just make it simple. They go to the temporal lobe. Okay. Some don't cross over. Here it is. Some do. Okay. Whether they cross over, whether they don't cross over, allows us to do different things with sound, which we're not going to get into. Okay, so they enter, they go to the auditory cortex, which is in this portion of the temporal lobe. All right. Once they're in that portion of the temporal lobe, so here's your primary auditory cortex, and again, it's like vision. You're hearing sounds come in, but they don't mean anything until your brain makes them mean something, right? So here's where they're coming in as sound. That information spreads out into the association areas so that you can say, hey, this is a high-pitched sound, this is a low-pitched sound, this is, a horn blowing, this is... this sound makes me very angry. This sound makes me very happy. Okay? That would be country music makes me very angry. And like heavy metal makes me very happy. I know that sounds like it should be opposite. But all that's happening in these association areas. Okay? So you have to make sense of the sounds you're hearing. All right, determining the direction of sound. Forget it. Let's go into vestibular. All right. The vestibular apparatus, they call it the vestibular apparatus and the vestibular nerve because it's in the vestibule. All right, so vestibular doesn't mean anything about proprioception or balance or anything. It describes where it's located, actually. So, again, these are still going to be in the temporal bone, in that petrous portion, and there's going to be 3 different organs. One is going to be the semicircular canals, which are these. All right, and they are located, they're oriented 3D. You have one that's like this, you have one that's like this, then you have one that's like this. All right, and that gives you a 3D orientation. And they're tubes filled with fluid. All right, you have the utricle, which is this big tube right here, and the saccule, which is this big tube right here. And we'll talk about what each one of those do. All right, well, here it is. The utricle and saccule, they detect orientation of the head with respect to gravity. So, if I'm standing here with my head straight up, like they're detecting that I'm straight up. But if I bend my head forward, these things are, I'll describe it in a minute, they'll detect that and have me contract these muscles so that I don't go, okay? So that's the way this works. So they detect the orientation of the head with respect to gravity. Okay, so here's how they work. You can follow here or like in your PowerPoint. I'm using these pictures here with this dude that's headbanging.
We have an extra slide. Oh, yeah.
Do I?
That one.
Ooh. This is actually even better. Good, sweet. The macula. All right. This is what they say, a gelatinous layer with these little stone-like structures inside of it, which makes it heavy. So imagine Jell-O with fruit in it, which is absolutely disgusting, but this is what it will look like. All right. If I'm standing like this, it's just going to be sitting there. But as soon as I tilt my head forward, those stones in there will make that jelly go forward, right? Like it's going to fall off the plate. All right? When it does that, that's going to activate these hair cells that it's attached to. Okay? So, I'm standing here. I tilt my head forward. The Jell-O starts sliding off the plate, and it'll activate hair cells. All right, and these are what the hair cells look like. What do they remind you of?
Yeah. I'm sorry.
In the cochlea, right? What's in the cochlea? So, when you bend your head forward and these hair cells bend, like the headbanging dude here, you're going to bend these hairs in this direction, and what do you think is going to happen? You're going to open up channels, and they're going to do what? Depolarize. But if I do this, the Jell-O is going to fall off the plate in the opposite way. And what's going to happen? Hair cells are going to go this way, and they're going to hyperpolarize. So the direction of your head is going to tell the cells to depolarize or hyperpolarize. That's how they send the signal. Depolarization would be forward, for example, and hyperpolarization would be back. Right? That's the signal that it's sending. So if they're depolarizing, it's telling your brain, hey, the head's moving this way, you might want to do something about it.
Is there a, like in the ear, how the shorter ones were higher or lower frequency and the bigger ones are higher? Is there a orientation of that, or just the concept of one bending one way is blank?
Yeah, so if they're bending towards the tall one, you've got this structure here that's going to help open up channels, which will cause the depolarization. But if you bend this way, those channels are going to close and it's going to hyperpolarize.
Right, but is there like one way is hyperpolarizing and one way is depolarizing, like the bending of the head? Or just
So you've got this, you've got this, you've got that, you've got that. So I don't know the answer to your question,
okay.
but I would guess that everyone's probably slightly different.
Gotcha.
And according to, your experience of doing this all the time, they're going to orient that way.
Gotcha.
Could you have like polarization or polarization at the same time if you moved your head and then like leave the other?
So if you're going like this, and your depolarization in one direction and hyperpolarization in another direction, you're sending two different signals to achieve basically the same thing, which would be opposing that motion over here. All right. So with this, what the goal of this, like it's detecting where you are in space. If you're going like this, basically you're falling forward, right? So going like this would be the same as falling forward, right? And what are you going to do if you start falling forward? You're going to activate muscles that prevent you from doing that. So these are the sensors that detect that you're falling, and they're going to send signals to your brain to say, and activate motor systems that oppose that direction. Good questions. Pardon? The answer to your question? Yep. But the specifics of it, like, are they rented, or are they just all over the place and they detect whatever? Yeah, we've already talked about this, right? Pattern of excitation tells where you are in relation to gravity. Okay. The semicircular canals. So that allows you, like, where you are in relation to gravity. The semicircular canals tell you, I told you how they're oriented. You have 3 orientations. That gives you 3D. They detect angular momentum. They detect angular momentum. So if you're rotating your head, they will detect that your head is rotating. Okay? If you're going like this, they detect that your head is moving in this direction or this direction. Right? They work the same way. All right? Let's see. Wow, I need to include better pictures in here. So these are your semicircular canals, and they're filled with fluid. At the beginning of these circular canals, we have this enlarged region, all right, called the ampulla. All right, and in there is this structure called the cupula. All right, again, a gelatinous mass, but it doesn't have the stones in it. So it's not going to respond to, it's not going to be heavy and be like jello falling off the plate. What happens here is that when you rotate your head, the fluid moves, goes all the way around that circle, and like a water slide, I guess, would be, it's going to move that cupula. Does that make sense? So turning your head will get fluid moving, and it will push on that cupula. So imagine you had like a tube of water, and then you start putting water through that tube, and the thing moves. Oh, like pools. Like pools. You know, above, actually the in-ground pools too, where you have the intake and there's that little flap, and as water's flowing in, that flap goes whoosh. That's what's happening here. The flap goes whoosh. It makes that sound too. Yes. Except it's really small and it sounds more squishy. All right. So, logically, if fluid's moving this and it's bending this way, what's that going to do? Bend hair cells, open channels, and cause depolarization. All right, so it's going to detect the rotation movements of your head. If I'm going, let me see, this way, like either way. If I'm going this way, or even if I'm like twirling around in a circle. So that would be this way. That would be this way. This would be this way. Okay? Not in relation to gravity, but actually movement of my head. Okay, the fluid in there is called endolymph. Okay? Here's how this works. There will be questions about this. When you rotate in one direction, the fluid moves in the opposite direction. Think about when you start driving. When you press on that gas, what happens? Right? When you hit the brakes. Okay? So whatever direction your head's moving, if I'm moving my head like this, the fluid's moving in this direction. Okay? And that's going to activate the hair cells. So if I do it like this, and the fluid's moving in this direction, and I go like this, the fluid's going to move back in that direction. So if I go like this, one, I'm going to get a headache. And two, that fluid is going to be pretty turbulent, all right? And the reason why you get a headache and don't feel good is because you're confusing the receptors, okay? We can test this, all right? Because what was the test you guys did of the vestibular system in class with Daniel? What was that called? Do you remember? Yeah, the Romberg test. So you stand there, one with eyes closed, standing on both legs, right? And you're looking for, or one leg, close your eyes. All right. Are you more steady with your eyes open or eyes closed? Eyes open. So what does that tell you about your vision and your its relationship to balance? Is vision required for balance? Yes. It plays a big role. Actually, okay, we'll put it this way. It's not absolutely required, but it helps a whole lot. Okay? So, the test we do to see how these semicircular canals work, because your vestibular system is connected to your eyes, take those stools that we have in the anatomage room, put somebody on them, and then spin them around. You ever done this test in labs? Okay, you stop them and you look in their eyes. If they have their head up like this and you're activating these semicircular canals, and look at their eyes will be going. They'll be going in the direction that you were spinning. Like, they'll go. What do we call that? Nystagmus. Okay, that is a indirect. It's indirect. It's an indirect demonstration of how those semicircular canals are working. And those of you who are looking at me confused, Lindsay was one of them. I think. I'm not picking on you.
Okay.
If you tilt your head, so now you're activating in another one, right? And you spin around in circles. And then you stop them, and they raise their head like this, their eyes are going to be going. It's really weird. Then, if you have them tilt their head like this, and spin them around in a circle, and sit them up, they'll be going around in circles. It's subtle, so you really have to be looking for it, and you got to pick somebody that doesn't get sick when you do this. Okay. If I can find it, I took a video of one of my students doing this, and it worked really well. So if I find it, I will post it out on Canvas for you. Or if I find something on YouTube that shows this as well, I can post that. But really interesting. So that's a good, that shows you how these work, and it shows you that the visual system is really tied into your ability to balance. All right, so where does it go from here? All right, there's your cochlear system. There's your vestibular system. All those little hair cells are tied to neurons. Those neurons bunch up and they form a nerve, and that goes out as our vestibular nerve. All right? Our vestibular nerve and our cochlear nerve combine and make our vestibular cochlear nerve, which is cranial nerve 8. It's right there. This sucks. Okay. Here's your vestibular nerve. All right? That information is coming in just below, what's this thing right here? Pons. It's coming in just below. It's going to have this is complicated. We'll make it simple. It's going to go